And I'm really hoping that as you have questions, you chat them in or you just interrupt us so that we can make sure we're clarifying and making sure everybody's needs are met. So I have a long expertise in doing research and documenting the significance of adverse childhood and adverse childhood experiences and social determinants of health. I really want to talk with this group about how do we build capacity and infrastructure to really universally screen and address trauma and adversity, and to talk about interventions that will prevent kids from having toxic stress, and for those kids that do have stress physiology, how do we actually create programming that can help support them achieve their best possible outcomes? Next slide. So in order for you guys to understand my land, it's really important that I describe the community that I serve and that I'm really honored to work in every day. So I am a primary care pediatrician. I work within a federally qualified health center, which is a safety net, meaning that the vast majority, 94% of our families have Medicaid, which is a proxy for the poverty level. And 90% of my families are also families of color, mostly African American, Latino, and an international population of Southeast Asian and Arabic speaking families and new arrivals. So I'm going to introduce you to one of my lovely families. This is Miss Johnson and her 3 kids. So I first had the pleasure of meeting these 2 twins, Joe and Jamal, after they had been in the emergency department about 10 times for their asthma. It became apparent to me that their asthma was a manifestation of the stress in their life. Miss Johnson's oldest son was recently murdered in Oakland, and shortly after the murder of her son, she got a call and wanting to know if she wanted to adopt these 2 young foster care kids. She already had their older sibling, who you see in the background. Both of these boys not only had severe, persistent, uncontrolled asthma, but also allergies and eczema, learning issues, and some significant behavioral concerns. We worked really closely with the family, and the boys were subsequently diagnosed with anxiety, depression, and PTSD. And Ms. Johnson had significant chronic medical issues, including diabetes, hypertension. She started on dialysis, and she's now currently on the list for a kidney transplant. As their pediatrician, if I don't talk about trauma, I'm not actually serving the needs of this family. And by collectively actually approaching all of our families with a holistic approach, talking about these upstream factors that are impacting health outcomes, we really can actually get these boys and their sibling on the right track. Next slide. So what we do know is that trauma is a public health crisis. What we do know is that there's an increased risk of death for folks that experience trauma for 7 out of the 10 leading causes of death in the United States, including diabetes, hypertension, cancer, homicides, and community violence. We know that trauma affects brain development, that it influences the way that our DNA is actually read and transcribed. Trauma triples the lifetime risk for heart disease and cancer. And if you have numerous traumatic experiences, they can actually reduce life expectancy by up to 20 years. Next slide. So continuing with this train of thought, trauma affects more than just one individual. It ripples to all of us that are in communities. And what we also know is that low-income communities and communities of color are disproportionately affected, such that discrimination, poverty, and trauma themselves can become toxic. We know that trauma is intergenerational and can get transmitted from mother to child. And we also know that it is systematic and it is preventable. Next slide. When I think of social determinants of health, my definition is very simple. To me, social determinants of health are the upstream factors about where we eat, sleep, live, and play, and how those factors actually profoundly impact our health. And so if you look at this picture, you can see the tent encampment, and that's on the side of the freeway by my hospital. I drive past it every single day, versus the homes in the very prestigious Oakland Hills. And these circumstances are literally within 3 miles of one another. Next slide. So when we think about what determines health, what we know is that it is very important to have high quality care and access to that quality care. But ultimately, that actually determines about 20% of our health. The larger picture is that it is our social and environmental factors that truly determine our health, right? And so we think about, is it genes or is it our zip code that affects our health? And both are important, but a lot of it is related to our zip code. Next slide. Can you guys hear me okay? I'm getting some feedback that they're having a hard time hearing.
Yeah, Dr. Long, this is Shawn. We can hear you just fine. It is possible for those folks who are on cell phone or in various areas that their internet connection may be a little choppy, and so we do apologize about that. But please, everyone, know that this is recorded, and you are welcome to listen to it afterwards as well if something happens. So
when we apply a lens of health equity to the work that we do and we think about health disparities, the way that I define health disparities are preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimum health that's experienced by a segment of the population. When we actually compare a white child that's born in those affluent Oakland Hills to an African American child that's born in the flatlands, we can see health disparities across the life course, such that as an infant, that African American child who's born in the flatlands is 2 times more likely to be low birth weight, is about 12 times less likely to have a mother who graduated from college, is 13 times more likely to live in poverty, is 4 times less likely to read at grade level, and grade level reading is highly predictive of educational outcomes. And as an adult, that child is 5 times more likely to be unemployed, 3 times more likely to die of a stroke, and within miles of each other in terms of where those children grow up, there's a cumulative impact of 14-year difference in their life expectancy. Next slide.
So Dr. Long, as I change to the different slide.
So what are ACEs? And
sorry.
Most of you have a lot of fluency with ACEs by this point, but just to briefly review, ACEs are adverse childhood experiences that came out of a study that was done in the mid-1990s between Kaiser Permanente and the Center for Disease Control in San Diego. The initial study enrolled about 17,000 participants, all Kaiser members, mostly male, mostly middle-aged, and they were asked to retrospectively reflect on their childhood. And they were asked to reflect on 3 different categories of experiences during their childhood. It was abuse, neglect, and household dysfunction. And so the abuse could be physical abuse, emotional abuse, or sexual abuse. Neglect was physical or emotional neglect. And household dysfunction, we are reframing to actually call it household challenges. Although the traditional literature in which the ACEs study was reported called it household dysfunction. And this involves any kind of mental illness, including depression, domestic violence, divorce or separation from caregivers, drug use, and imprisonment and incarceration. We wanted to think about how can we actually look at ACEs as a prospective screening tool, and how do adverse childhood experiences actually affect children. Next slide. The research has dictated to us that ACEs have a dose-dependent relationship with health outcomes, such that children who experience 4 or more ACEs are more likely to have pulmonary disease, are more likely to have heart disease and cancer, are 4.5 times more likely to have depression, and are 32 times more likely to have learning and behavioral issues. I just want to reiterate that children who have 4 or more ACEs are 32 times more likely to have learning and behavioral issues. And this is particularly important for our schools to understand that a lot of kids who might be struggling in school have experienced significant amount of trauma in their life. Next slide. So what is stress? And how does stress actually impact our physiology? Well, there are actually three different types of stress, and this research comes out of the Harvard Center for the Developing Child by Dr. Jack Shankoff. And what he poses is that there's positive stress, and positive stress is associated with brief increases in heart rate and mild elevations in stress hormones. So, for instance, this morning when we were having some technical challenges, I would imagine, Shawn, that you were undergoing some positive stress, and that it has since resolved, right? Tolerable stress is stress that is more serious but temporary, and it is buffered by having supportive relationships with adults in your community. We refer to toxic stress as prolonged activation of our neuroendocrine system in the absence of having protective, safe, stable buffering relationships with adults. And so what is an adaptive process becomes maladaptive, and you have this constant load in your system of adrenaline, of norepinephrine, of cortisol. And so what was adaptive, such that if you were being chased by a lion, it's important that you can run as fast as you can or climb a tree, right? That's what epinephrine and norepinephrine do for you. The problem is when that lion comes home every single day, you have a constant activation. And then the symptomatology might be that you're hypervigilant, that you're hyperactive, that you can be impulsive. Next slide. So we have to actually examine what are the nature of the stressors that children are being impacted by. What is the trauma? What kind of access do children have to safe, stable relationships and communities? And what is the demographics that are being impacted by that trauma? Is it violence? Is it issues in the neighborhood? Is it air quality? Next slide. You can just run through these fast, Shawn. We have to think about how that stress is perceived, such that each individual has variations in their gender, their genes, their experiences and behavior, so they will respond differently to stress that they perceive, and that manifests as their ability to cope. And then we have to look at what is that biologic response to that stress. What happens to our neuroendocrine system, to our immune system, to our DNA? How are genes and the environment interacting? And it even impacts the type of bacteria and germs that are in our system. Such that oftentimes when kids are stressed, they might have more colds. They might actually have more different types of stomach viruses. And it's because there are different types of bacteria, when your system is weakened, that can actually overgrow and make you sick. Next slide. What we have come to understand is that trauma and stress really get underneath our skin, and they can affect every level of our bodies, from our brain development and our central nervous system, areas of our brain that affect executive function, areas of our brain that affect the ability to be satisfied and to be happy, areas of our brain that affect our anger centers. And it affects our peripheral effects, our nervous system and our immune system, with end organ impacts on our lungs. It affects how we actually respond to diseases. It affects our brains. Next slide.
So Dr. Long, while I move over to the next slide, you mentioned something before. You said that it can even
Yes,
it can even affect our DNA.
It's not actually affecting the way that our DNA, our base pairs are actually wound together. It's affecting the way that our DNA is read, such that our DNA is temperamental and it's influenced moment to moment by our experiences. And so what we've learned, for instance, in African American men, they have shorter telomeres. Telomeres are the caps of our DNA. And the shortening of telomeres is related to accelerated aging. We've learned that within DNA you can get these caps that when DNA is read, it makes the proteins that read them actually skip a region. And all of a sudden what was a disease-free process now starts coding for diabetes or obesity. And so the trick is stress can actually turn these switches on.
Oh my goodness.
The holy grail is, how do we turn them off? And that's what we're trying to figure out right now.
Yeah, well, it goes beyond just health, right? I mean, it sounds like outside of just health as well, it's a huge financial and overall societal issue. I mean, this is really big.
So trauma
Why is
is
this
a
not
public
being
health
spoken of
crisis.
more?
And it is imperative that as advocates for children and family, we talk about this every single day. We talk about the amount of dollars that we're spending on healthcare for our country. But oftentimes the highest utilizers of the healthcare system, the root cause of their disease is trauma.
And so on this slide, you
So
talk
we know
about
that
brain
the first
development.
5
What's
years
this all
are
about?
really critical windows for brain growth and development, for language and emotional development. So when a child is born, they have about 80 billion brain cells, and it is how these brain cells connect with one another that really determines who and what we are. So on average, babies' brains are making about 700 connections per second, every second, in all parts of the brain. And the parts of the brain that are responsible for regulating feelings, for learning language, for problem solving, for understanding how to interact with people. And the way that these connections are made, the way that these cells grow, form connections and are very sensitive to our social environment. The more safe, the more stable, the more rich our environment, the more brain connections can be made. And the more practice that babies get generating these brain circuits, the better they become at developing them. So a child's ability to learn in school, it largely depends upon skills, right? And these skills are sharing, impulse control, the ability to retain information, the connections that they develop within those first 1,000 days of life. When a child is exposed to immense amount of stress and trauma, their brain, rightly so, will shift from cognition and language development to how do I survive in this situation? And you can have dysregulation of a normal system that shifts what babies should be focused on to basically just being able to get through the day. And it is this ability to shift, we call it the plasticity of the brain, that makes children super vulnerable to adversities, as well as incredibly adaptive and resilient. Next slide.
Wow. So, and this happens all before, this development happens before 5, and you were sharing with us, based on where you can even live, that can affect the stressors that affect your,
That's right.
your
Those
development
first 5 years
before
are
you're
really
5.
critical to brain development, and they're when kids are most vulnerable to traumatic experiences.
That makes a lot of sense as we focus on, pre-K and early childhood. There's a big movement going on, but that movement's mainly focused around the academics. And what I hear you saying is that we also need to be focused on the stressors and the societal conditions that these youth are being brought up in, which is a direct link to poverty, I think, right?
And that stress is caused by issues of food insecurity, of housing instability, of community violence, of discrimination, of being separated from your caregivers, of having mental illness in the family.
So I know you said it can also affect some behavioral things, and I think on your next slide here you talk about that.
That suggests that when children are exposed to ACEs before the age of 5, there are higher diagnoses of learning and behavioral issues, including ADHD, in those children. This literature, I give the citation, but I'm also going to share some of our data. So when we asked caregivers to fill out an ACEs screen on our children within our clinical setting, and the average age of our child within our pediatric clinic is 5.8. What we found is that, understand, these children are 5 years old. We found that 80% of our kids had been exposed to at least one traumatic experience, and we found that 54% of our kids had already been exposed to at least 4 adverse experiences. The research suggests that if children are exposed to 4 or more adverse experiences, right, they So they already are set up 32 times more likely to have learning and behavioral issues, as well as a reduction in their life expectancy. So this just drives home this point that the higher the ACE score, the more likely you are to see learning and behavioral issues. Next slide. So the health outcomes of ACEs really affect us over the life course. And it's a misnomer to think that, oh, children are too young to know, because it's not true. If a child is in a home and there's domestic violence, or if there's a death of a caregiver, that baby might not be able to speak those words, but their body knows. And so over the life course, it might be that that infant has some growth delay, some cognitive delay, some sleep disruptions. As they become school age, they're more likely to have asthma. And within my patient population, about 40% of our children are diagnosed with asthma. The national average is 12%. They're more likely to have infections, learning issues, behavioral issues, and as adults, those symptomatology are related to obesity, to having high-risk social behaviors, to violence, to teen pregnancy. Next slide. So adverse childhood experiences can affect people in multiple ways. And so if you look at the top curve, a child could be exposed to ACEs and not show any symptomatology at all and have a super productive, super healthy life. A child can be exposed to ACEs and not show any symptoms, but still have a shortened life expectancy or disease. Or a child can be exposed to ACEs and have significant disruption in their neuroendocrine system, significant concerns about their social, emotional, and cognitive abilities, and adopt high-risk behaviors early on in life. This just goes to show that there's a lot of individual variation, and we need to make sure that we are creating programs where we can create primary prevention so that even if you are not showing symptoms, you still can actually have an intervention that helps to mollify the effects of toxic stress so that you do not develop disease, as well as interventions that are treatment for kids who are exposed to a lot of trauma in order to make sure that they can be on the healthiest trajectory possible. Next slide.
You know, Dr. Long, it's interesting as you're talking about this. You know, as we are out in society, we hear a lot like, "Oh, you have this illness; it must be genetic," or, "Oh, you're obese. Well, you know, get on the treadmill and work out a little." And yet, you know, there's this direct link to stressors and the ACEs to health. It's interesting that, you know, that's coming out. Is that getting into the mainstream? Are more and more people starting to realize this?
I feel as if the national conversation is shifting such that the dialogue is no longer, you know, what is wrong with you, but what happened to you. And that's a much more productive question to address root causes. So I feel like that shift in narrative is actually happening. And it's happening because there are a lot of us out there pounding the pavement and making sure that people are listening.
I was going to say, I know you're going to start talking a little bit about your work around this, but how did, if you don't mind, we haven't really talked a little bit about you and how you got into this, and that may be a part a little later on, but could you just give us a preview of, you know, did you think you would be on this trajectory working with this particular aspect in the field of medicine, or did you expect to go somewhere else?
That's a really great question, and I appreciate it because I often put one foot in front of the other without having a true final endpoint. Because ultimately, you know, if you look at a logic model of theory of change, the endpoint is how can all children be as healthy as possible. So growing up, I grew up in a household of teachers, and the importance of social justice and education was made aware to me from I used to go to graduate school with my mother when I was a toddler because she had no child care for me. So I would sit in her classes with her. And so this notion of how important education is has been in the forefront of my mind my entire life. After I went to Stanford and after I graduated, I really wanted to serve my community in a real way. And so I was part of the first AmeriCorps class. And I worked with youth who were homeless in Los Angeles. And we tried to connect kids to services. We talked about HIV and AIDS. We talked about issues of rape, about where kids could get food. We did STD checks. And that really helped to confirm that, my goals are how can we actually help everybody thrive? Going into medical school, I didn't know that I wanted to be a pediatrician. That happened once I was actually on my pediatric rotations. And coming to Oakland, I fell in love with my hospital and my community, and it became so obvious that simply giving vaccines or refilling asthma medications wasn't actually helping my patients get better. And especially when you start to look at disease processes like asthma, if you have a child like the children that I talked about who have been in the emergency room 10 times and all you're doing is refilling their inhalers, at some point you need to say, I need to do something different if I actually want to make a difference. And the research started because I wanted to think about what those upstream factors were and think about upstream factors like determinants of health and trauma in the same rigorous way that we think about medicine as a whole.
You have such an amazing history, Dr. Long. I mean, the fact that we're chatting in the chat room, a couple of other folks, like you started as a toddler. It's like you were born to go on this mission. So how fascinating. And how's your work? Like, I think that's where you're going next.
Absolutely.
Is what your work is turning into,
and
right?
So for those of you that have heard Dr. Nadine Burke-Harris speak, she's our first Surgeon General in the state of California. Her and I got together in about 2013-14 to form the Bay Area Research Consortium on Toxic Stress and Health. It was a collaboration between the organization that Dr. Burke-Harris led, the Center for Youth Wellness, and myself at UCSF Benioff Children's Hospital, Oakland. It was a multi-institutional collaboration really dedicated to advancing how we as pediatricians identify, measure, and address childhood trauma. Next slide. So we had 4 main goals. The first was to identify important risk factors at all levels of childhood and develop a prospective pediatric screening tool and to examine associations between ACEs and health. We wanted to look at risk factors and how risk factors were related to what we call biomarkers or biologic processes, such as related to your DNA, related to the type of bacteria you carry. We wanted to know what were the crucial times to intervene and what were some of those interventions. Next slide. So ultimately, we created a package of developing a prospective pediatric screening tool that we call PEARLS. We developed a symptomatology list so that we could actually look at kids who screen positive and see, all right, there's a higher propensity for kids that have ACEs to have stomach aches, to have headaches, to have asthma, to have missed days of school. And then I want to talk about some of the interventions that we developed. Next slide. So we looked at the traditional ACEs screen around the categories of abuse, neglect, and household dysfunction, and we ultimately decided that we wanted to add a 4th domain to that original ACEs screen that addressed these determinants of health. Out of the long list of these unmet basic needs factors, we wanted to create correlations between what are those basic needs and what is the evidence base of biologic disruption such that these determinants of health have the same effect as the traditional ACEs. And we settled on food insecurity, housing instability, discrimination, and violence outside the home. Next slide. Next slide, Shawn. we put these questions together in a screener, and the screener has two parts. Part one are the traditional questions, and part two are the extra questions. And we went through all of the original ACEs questions, and we iterated on each single question, making sure that it was culturally appropriate and humble. There were some changes that we had to make in the tonality of the questions, including taking out his or her, making sure that we were saying you, your child. We expanded the language around the mental health question because in a lot of communities, particularly in communities of color, if you just ask, do you have concerns about mental health, the endorsement rate will be really low. And so we reframed that question to say, do you live with a caregiver who often seems to be sad or to have depression? We also expanded the language of the questions to really look at social cohesion and networking. And so it's not necessarily that the child lives with parents who are communities. A lot of parents are co-parenting and never actually officially married, but the issue is, did a romantic caregiver move in or move out? Was that child separated from a parent? We created a teen version of this survey too, and that teen version has two more questions around, was the teen themselves ever detained or incarcerated, and is the teen themselves in a domestic violence relationship? Next slide. That is the exact place that I'm getting to. So I'm going to answer that question. Just give me 2 more minutes because that is exactly where we're at this point. And so this screen that we created, we wrote it up in a peer-reviewed journal. And then next slide, the most amazing thing happened. We worked with our local state legislator, and we proposed a bill that went to the California Senate. That bill is called AB 340, and it is a bill that mandates trauma screening for every single individual in the state that has Medicaid. That is about
So while we move to the next slide, Dr. Long, do you mind if I ask a few questions that are in the chat room?
As law in California, and the governor signed a budget as of
so one of the questions we had is, how do you get pediatricians to put these screeners in their office? Or do you work with other community resources?
8,800 clinics to start to use the Pearl screen that we created here at Children's Hospital with the Center for Youth Wellness, and another $60 million funds to be spent over 2 years to help to support the capacity, infrastructure, knowledge and skill of providers to administer the trauma screen. We are at a place right now that as of January 2020, these reimbursements for states is going live, and PEARLS is now the only tool in the country for trauma in the pediatric population that is endorsed and incentivized by a state government. And our goal is that every other state in the nation is going to follow what California is doing. So I love this question, and I see that Sam chatted that question about how do you get started? And my answer is, when I first started this, it was almost a decade ago. The place that we started, it was so small, it was a simple pilot. What I realized is that we had no way of systematically even talking to families about trauma and unmet basic needs. And so we started a study, and I can send it to you, Shawn. It's called iScreen. And we programmed an iPad.
So any advice for those on the line? We have a question in the chat room, 2 questions actually about this is amazing, but like, how does like a single organization, get started on something like this?
And the feedback that I see
Also, can educators
well-meaning
learn to screen
colleague
children, or is
was,
it
"This
only
isn't our
health
job.
professionals
We don't
and
have time for
practitioners?
it. I'm not going to ask the questions because I don't know what to do about the answers. And Dayna, you're not going to solve poverty. This is much too much to take on." But we started and we persisted, and we were able to get to this point because we collected rigorous data that is the gold standard for our field. And what we did are multiple, what we call randomized controlled trials. And we collected and generated so much data that the data itself became undeniable. And then we also had the stories that back up the data. And so when we were on this legislative work group, I was able to present the data and say, within our patient population, for our adults, 90% of our adults have at least one ACE, and almost half have 4 or more. And our 5-year-olds, 80% of them have 1, and over 50% have 4 or more. What we do know is that these ACEs are impacting health outcomes, they're impacting absenteeism from school, and ultimately they're affecting the bottom line of our national budget because they become the highest utilizers of the healthcare system. Yes. Yes. So the high vision and dream is that we're able to mandate legislative policy change that not only supports the health sector in doing clinical transformation about being more trauma-informed and doing screening, but that this policy landscape, it needs to be much broader. And so it's great that now clinics are being reimbursed to screen for trauma. And then what happens is this recognition that, you know what, 1 in 5 of our kids are screening positive for food insecurity.
You did say 5 years old, right? Have 4 or
We need
more
to work and
ACE?
connect with food banks to make sure that our kids are eating. And schools are doing great at this.
And so where's this evolving into now that, like you said, you started, you just kept plugging away, you collected data, you built your case, you matched it with stories of the community, you have this passionate group, and it's building into
we know that 50%
some
of
further
our
work
kids
you're
are
doing.
being separated from their caregivers, and it's happening every single day. We see it on the news. And so this is one step to get providers to be incentivized to screen, and there needs to be rapid policy change now to support referrals and community-based organizations so that we can actually send these kids out to get services.
Yeah.
And I do find that a lot of states follow what California does, and so we need to be advocating. We need to be talking to our legislators about this every single day. So the ultimate goal is resilience, and this is a quote from Jack Shinkoff that says, "In the final analysis, resiliency is rooted in both the physiology of adaptation and the experiences we provide for children that either promote or limit its development." I love this definition because it talks about the physiologic aspects of stress and the fact that it is the responsibility of us, the community, the adults, to actually make sure that we are supporting children or we are limiting their development, and that is our choice. Next slide.
I'm like sitting here like,
hallelujah,
yes, let's make it happen.
Of the caregiver and the child. We really focus on caregiver resilience, on social connections, making referrals for families. We focus on improving knowledge of parenting and child development, including social emotional skills. We provide concrete support in times of need, such as we have a diaper bank. We have food that's within our clinic itself. We also focus on the self-regulation of the child. And one of the ways that we did this for the research is that we have these resiliency groups. The resiliency groups There were about 6 to 8 dyads and caregivers and children, and it was focused on mindfulness, on self-regulation, and on co-regulation, such that even a young child is able to recognize, are they in their upstairs brain or their downstairs brain? And this is about executive functioning, so that when a child is upstairs, they're making good decisions. When they're downstairs, they're rageful. And being able just to identify, young children can do this. Are you upstairs or are you downstairs? And what happens in your body when you're downstairs? And so we're able to have young children, right, 4, 5, 6-year-olds say, when I'm downstairs, I hit with my hands because I get angry. And that is really important for them to actually be mindful of how that stress, how the rage and anger is actually manifesting itself in their body. We also have an intervention that's based upon just getting families out in nature. There's a lot of evidence to support that nature itself is a buffer, and so we have a program called SHINE, Staying Healthy in Nature Every Day. It was just featured on the PBS NewsHour, where caregivers and children go out with their providers once a month together in nature. And for each of our trips, we have about 80 or 90 individuals attending, and it's really special. Next slide. So when we think about caregiver buffering, there's a biologic process that happens when a child feels like they're in tune with the adults in their life. It's called biosynchrony, and it's really important for human attachment. And it can happen between a mother and child, a father and child, a grandparent and a child. And it is, you actually see what's happening on a biologic level because you can actually see heart rate coupling. You can see respiratory rate coupling. You can see a coordination in the types of hormones that are released. And you can actually look at brain waves when a child and adult are in synchrony. And this is the goal. Next slide. The interventions that we piloted within our clinics are, the first is very short and simple anticipatory guidance. So anticipatory guidance is the advice that we give as pediatricians to talk about stress. And what we say is that stress affects our heart, it affects our mind, and it affects our bodies. And hard things happen all the time. We are never going to be able to make the hard things go away, but we can impact how we respond to that stress. We trained all of our staff to deliver this anticipatory guidance. We use an acronym, it's called NOTE. And so the N stands for notice the relationship, notice the interaction between the parent and child, and then comment on it. You know, it looks like Johnny loves it when he sits in your lap. Or have you seen that every time you smile at her, she smiles back at you? Or look at the way she's babbling and cooing to you. The O stands for offer the science, and it can be simple. What we know is that stress gets underneath our skin. The T stands for tools, and so the reason why we want to talk about this is because we have tools and resources that we can share in order to make sure that Johnny is as healthy as possible. And then the E stands for empower. And one of the things that we don't do enough is simply to say, parenting is hard, and you are a good parent. Those simple words matter so much for families. We also are using community health workers to screen families for unmet needs and determinants of health using a platform we created called FINDconnect that automates the process for screening, referral, case management, and data de-identifying and aggregation. And then the other clinical intervention are these resiliency clinics that I was talking about. Next slide. So here's a picture of my clinical team. So that's me with the pager on. And then it's my little cutie pie, my 7-year-old and her mother. Our mental health clinician, she has the key on her badge. And then flanking us with the glasses are my community health worker and our volunteer. This is our team, and we really try to practice a team-based approach so that when this family took the ACEs screen, their ACEs score was 7. And I can tell you that in the room with the family, even I had this moment of panic. Like, what am I going to do? This child's ACE score is 7. And then I realized, you know, I have a whole team working with me. I can call my mental health clinician. I can make sure I can get them food today. I can let them know about play groups and activities so that they get connected to their community. Next slide. So the model that we're using in our clinic is that we universally are using this Pearl screen. It's offered to everyone. For families that need help with basic resources like after-school programs, access to green space and food, we connect them to our community health workers. And for families that have more complex needs, we refer them to social work, to developmentalists, to therapists. Next slide. So this is our cloud-based system that we developed. You can look up www.FINDconnect.org if you want to learn more about it. And I'm not a technologist. I just have to say that technology was a tool, and it's a tool that we needed in order to make connections between families who need resources and the resources that exist in our community. Next slide. Community health workers are really the crux of all the work that we do. They help to facilitate trusted relationships. They're a really central part of our medical team. We try to get a diverse group of navigators working with us. They enable all staff to work at the top of our license, and that they use technology as a tool to increase efficiency and capacity. Next slide. This just goes through the benefits of using a platform like FINDconnect, and there's a lot of platforms out there like Find right now. It was just really important for us to have one central location where we could have standardized screening and assessments. We can create action plans that are driven by families. There's a robust knowledge base of community-based resources. There's case management features. It allows for scalability, for outcome tracking, for QI and evaluation. And the training that goes into this is that your entire clinic really needs to strive to be trauma-informed and culturally humble. Next slide. Next slide. We can skip over this, Shawn. Next slide. So one of the great things about data, and this was Sam that asked this question, is that you can actually use the data in order to make your point to senior leadership or to legislators. And so this is a map of the Bay Area, and it's a map of where families have the most needs within our communities. And so the red zones are where families have the most needs. It's where there's a concentration of poverty. And we're entering this information into a digital platform so that we automatically can scroll over these hot zones and say, these are where families are coming from where they have food insecurity or the most concerns about their child's development or housing instability or the need for legal services or the fact that they don't have heat or their water working. We also are able to screen and look at zip codes for where adults are screening that have positive mental health issues or where the highest ACEs scores are. And this is a great advocacy tool for us.
Okay.
Next slide. So if you're interested in FINDconnect, just email me. Shawn, I'm happy for you to broadcast my contact information. We created FINDconnect because I work in a
Hey,
safety
Dr.
net,
Long, two
and for
things
those
real
of you
quick.
that work in nonprofit or
For those on the line, it is, we are at time,
there's
but
never
honestly,
enough
the
money,
content
and you
has been
always are
so
just
rich.
trying to be
Dr.
as
Long has so
resourceful as
much
possible.
amazing material that I would
FINDconnect is
ask
super
you to hang out with us
inexpensive
for
and
another
it's
5 to
really
10
easy to
minutes,
deploy, so
just so
if
that
you're
we can
interested, let
get
me
through
know.
some of the
There
final
are
thoughts,
fancier,
especially since we
flashier
kind of started
products
just a
out
little
there,
bit late due
and
to some
it was
tech
just,
issues on my
we
side.
just never
So
could
sorry
afford
about
them,
that.
so that's
But
why we created it.
I think the content is enough that if you could give us 5 or 10 more minutes, I
I
think
only
you would be
have
very
2 more
pleased.
slides,
And
and
then,
it's
Dr.
really
Long, we
about
have a
becoming
question, and that is,
trauma-informed.
are there other platforms like Find? Are
Oftentimes
any of them
organizations,
free? How can
especially
people
organizations
get like
that
Find
are
in their
safety nets and
community and start
nonprofits, are really
doing
trauma
that too?
organized, which means that they're very reactive. Um, there's often a lot of burnout. There's numbing amongst the staff. It feels fragmented and chaotic. There's often inequity amongst the hierarchy of staff and authoritative leadership. These types of systems are very painful to work in, and I have to say that we were there a little while ago. And we are moving towards becoming a healing organization that is much more reflective, such that we have regular huddles amongst our staff. We give out star cards when we see folks doing a really good job. We try to make meaning out of the past, and we have this growth mindset that is much more collaborative and accountable. And we're focusing on relational leadership, whereby there can be more fluid conversation amongst all staff. Next job. Next slide. My lessons learned from this work are, this is hard work, and it takes a lot of grit and a lot of blood, sweat, and tears. Sometimes what I've learned is that you really have to fail to know where you're going next, and the most important thing for organizations who are going on this journey is to really understand the impact that trauma has on the individuals they serve, on their community, but also on the staff themselves. If organizations are going to adopt this PROL screen, staff needs to be able to have a place to reflect on their own vicarious trauma and support groups so that they're not triggered when a patient has a positive screen. We really want to focus on universally screening in order to normalize trauma. Just like when we were having the HIV and AIDS epidemic in the 1990s, having HIV was very stigmatized. And trauma is the infectious disease of our time, and we have to normalize it so that we can talk about it, because by not talking about it, we're not going to make it go away. We need to focus on our data management capabilities. One of the reasons why we've been so successful is that we've had great data. We've really focused on developing partnerships outside of UCSF. These partnerships are with community-based organizations like our libraries, our Head Starts, and our food banks. We involved our community from the beginning, and so the tool itself was created through a rapid iterative process with our patients. It has to be iterative. We had to consider sustainability in the design such that in order to really incentivize clinics to start to screen across the state for all 31 million individuals within our state, the clinics had to be incentivized to be reimbursed, which is why it was so important for us to lobby and to get this bill passed so that clinics are going to be reimbursed about $30 per screen that they do. And that $30 per screen quickly adds up when you talk about the fact that clinics have about 32,000 to 50,000 patient visits a year. And that money can be used to sustain programs and interventions to support the kids who screen positive. And then the last thing is just to make sure that everyone's roles and responsibilities are really clear and really respected. Next slide. There are so many opportunities for data sharing, for practice change, and for developing innovative, viable payment systems. And I'm going to leave it at there because I know we started late, and so I want to make sure we don't keep people too late, Shawn, but I'm happy to stay on the line and answer questions.
Excellent. So, well, I'll go ahead then. I will show just some of the final slides. The slide deck, everyone can download the slide deck. If you look in File Share over to the right side of the screen, Dr. Long presentation, you can download her slides. This is a great picture of her and Dr. Nadine Burke-Harris there. But she also says, there's the vision for the future, talks a little bit about, how we can disrupt this link between adversity and poor health. She is very, very kind, or I think you're very kind, Dr. Long, for putting your contact info right in the slides. So as you mentioned, you said, folks can email you with a couple of questions. And then being the amazing researcher, physician, and professional that she is, she cited everything. So that makes my life a lot easier. So thank you so much.
I do sleep when I can.
As we go out, we're going to stay on the line for just a little bit and go ahead and answer any questions that folks may have in the chat room or around. But I just wanted to personally take a moment to tell Dr. Long thank you. She is, as you can tell, she is a very, very busy woman who is not just impacting change in her direct area and in the state of California, but the movement that she has been so critical and been such a advocate for is really going across the nation. And when we were talking about the Perspective show, we really wanted to delve into this health disparity around trauma. And Dr. Long, you hit it spot on. It's amazing. Do you sleep at night? Like, when do you have time to do all the stuff you do?
What I've learned is so important is that we all just have to keep going. Find your focus and just be tenacious. And every single day is a new day to actually
Wait. So not
goal.
only are you doing all this work and working with all these families, but you have 3 young boys at home?
Rooms and I see my patients, and how could you not want to try your best when you know everything that they're going through, and yet they're still giving you a hug and smiling?
Oh my goodness! Each level, that's amazing. How you stay sane? You got to share your secret. So there we go. Monique is sharing in the chat room that you're a superhero, and I cannot reiterate that enough. You really are. You're doing amazing work. Is there any, as we wrap up here, would there be a final thought that you would want to share with everybody?
Westat Gomez. She'll also be, our next webinar will be on January 21st, also with Lizette Gomez from Children's Aid Society.
It really brings perspective, doesn't it? Wow. Well, I applaud you. I thank you for taking the time. Everyone on the line, I know we went a little bit over, and that was my fault. We'll make sure that doesn't happen again in future shows. Please join us if you have time to join us in Orlando at the Beyond School Hours Conference, where Dr. Long will be in the live talk show. We get to talk to her face to face. If you're like me, you can then pull her afterwards and ask all these amazing questions that you may have. But join us there, because she's going to be our guest along with Dr. Laley. And thank you. Yes, I was like, I had a Shawn moment for a second.